Welcome back to the final part of our hematology series, lymphoma and plasma cell disorders. We start with Hodgkin versus non-Hodgkin, work through the aggressive B-cell lymphomas and their translocations, sort out the plasma cell disorders, and finish by splitting B-cell from T-cell. Let's finish strong. We start at the top, Hodgkin versus non-Hodgkin lymphoma. One cell on the biopsy anchors the whole diagnosis. What is it? Hodgkin lymphoma is anchored by the Reed-Sternberg cell, a large binucleate cell that stains for CD15 and CD30. Hodgkin classically presents as painless cervical lymphadenopathy in a young adult, spreads in an orderly, contiguous way from one nodal group to the next, and often comes with B symptoms: fever, night sweats, and weight loss. Non-Hodgkin lymphoma is everything without Reed-Sternberg cells. A huge family of B-cell, T-cell, and NK cell tumors that tend to spread unpredictably, often involve sites outside nodes, and are defined by flow cytometry and cytogenetics. So Reed-Sternberg cells with CD15 and CD30 are Hodgkin, and their absence is non-Hodgkin. Now the aggressive B-cell lymphomas. Burkitt and diffuse large B-cell lymphoma both grow fast. The histology and the translocation separate them. Burkitt lymphoma is the fastest one. It is driven by the MYC gene through a translocation between chromosomes 8 and 14. The biopsy shows a starry-sky pattern from macrophages clearing dead tumor, and the proliferation index is close to 100%. Endemic Burkitt, linked to Epstein-Barr virus, gives a jaw mass. Sporadic Burkitt gives an abdominal mass. Diffuse large B-cell lymphoma, DLBCL, is the most common non-Hodgkin lymphoma in adults. Sheets of large CD20 positive B cells forming a rapidly enlarging mass. So a starry sky with the MYC translocation is Burkitt, while sheets of large B cells are DLBCL. Two B cell lymphomas defined by their translocations, follicular and mantle cell. One is indolent, one is aggressive, and each has a signature gene. Follicular lymphoma is indolent. It comes from a translocation between chromosomes 14 and 18 that overexpresses BCL2, an anti-apoptosis protein, so the cells will not die. You get painless, waxing and waning lymphadenopathy, a follicular growth pattern, and CD10 positivity. Mantle cell lymphoma is aggressive, typically in older men. It comes from a translocation between chromosomes 11 and 14 that overexpresses cyclin D1, which drives the cell cycle, and the cells are CD5 positive. So the 14-18 translocation with BCL2 and an indolent course is follicular, while the 11-14 translocation with cyclin D1 and an aggressive course is mantle cell. Now the plasma cell disorders, all defined by a monoclonal protein. The question is what that protein is doing, causing end organ damage, thickening the blood, or nothing at all. Multiple myeloma is a malignant plasma cell tumor with a monoclonal protein, plus end organ damage, captured by the mnemonic crab, high calcium, renal failure, anemia, and bone lesions. The bones show punched out lytic lesions, the smear shows rouleau, and the urine carries Bence-Jones light chains. Waldenstrom, macroglobulinemia, makes a monoclonal immunoglobulin M that thickens the blood, causing hyperviscosity, but it does not cause lytic bone disease. MGUS is the benign precursor, a monoclonal protein with no crab end organ damage, found incidentally, that can slowly progress to myeloma. So crab with lytic lesions is myeloma, immunoglobulin M hyperviscosity, without bone disease is Waldenstrom, and a monoclonal protein with no end organ damage is MGUS. Finally, the lineage split that ties the series together. Once you know it is lymphoma, is it B-cell or T-cell? The markers and a few classic syndromes give it away. B-cell lymphomas are the majority. They express CD19 and CD20 with surface immunoglobulin and light chain restriction, and they include follicular, mantle, Burkitt, diffuse large B-cell, and CLL. Their translocations are the ones we just covered: BCL2, MYC, and cyclin D1. T-cell lymphomas express CD3 and come with classic syndromes. Adult T-cell leukemia lymphoma from HTLV1 with hypercalcemia and flower cells. Mycosis fungoides and its leukemic form Sézary syndrome, which involve the skin. And anaplastic large cell lymphoma, which is ALK positive. So CD20 with light chain restriction is B cell, while CD3 with a skin or HTLV1 clue is T cell. Let's lock it in. Reed-Sternberg cells with CD15 and CD30 are Hodgkin. Their absence is non-Hodgkin. A starry sky with the MYC translocation is Burkitt. Sheets of large B cells are diffuse large B cell lymphoma. The 1418 translocation with BCL2 is indolent follicular lymphoma. The 1114 translocation with cyclin D1 is aggressive mantle cell. For plasma cells, CRAB with lytic lesions is multiple myeloma. Immunoglobulin M hyperviscosity is Waldenstrom, and a monoclonal protein with no end organ damage is MGUS. And the lineage split CD20 with light chain restriction is B cell, CD3 with a skin or HTLV1 clue is T cell. That completes the hematology series: anemias, bleeding and clotting, leukemias and marrow, and now lymphoma and plasma cells. Thanks for studying with Mastering Medical.